So over to you, Bhavani.
Yeah. Good evening, everybody. I'm Bhavani, one of the trust specialist registrar in ITU. Today, I'm presenting high quality supportive critical care. What are the things I have to discuss in the slides? Um, Regarding ICU, what makes an ICU different from other wards? Rationale behind the ICU intervention, level of care, and supportive management. Um, what is ICU? A specialty staff and equipped area of hospital dedicated to the care of the patient with life-threatening condition. What are the things we are doing? Basic daily management needed for any critically ill patient to prevent or surmount common problems. The high quality intensive care, it means disease specific therapy, respiratory care, high intensity nursing care, and high quality supportive care. What are the levels of care? We can divide it into level 0, 1, 2, 3. What you mean by level 0? It is normal ward care in an acute hospital. Level 1 means it is in the ward setup, acute ward setup. With they can get additional advice from support from the critical care team. Level 2 means that is HDU, single organ support or post-operative care patient, or step down from the level 3 patients are there. In level 3, it is patients requiring advanced respiratory support alone or basic respiratory support together with support at least 2 organ system. This level include a complex patient requiring support for multi-organ failure. I will discuss with the supportive care. But as supportive care, we can look in the ITU as thromboprophylaxis. About 13 to 31% DVT patient without thromboprophylaxis, they will develop DVT. Much higher in trauma patient. All the patient to receive at least subcutaneous heparin unless contraindicated. What are the contraindications? There are hemorrhage or evidence of thrombocytopenia if the platelet count less than 30,000 or if less than 50,000 with falling trend, we have to avoid the thromboprophylaxis. Or in ICU patient, usually the procedures we never withhold the thromboprophylaxis unless if indicated. What are the indication we will withhold the thromboprophylaxis? In lumbar puncture or radiological intervention, they will ask to stop the thromboprophylaxis for intervention radiology. If the patient having GFR more than 30 ml per kg per minute, we can consider enoxaparin. If GFR is less than 30 ml per kg per minute, we can consider unfractionated heparin. Um, Next, nutrition. All the patient must be fed unless there is a contraindication. What is the important for the nutrition? It prevents the malnutrition. Apart from that, it maintains the gut integrity and prevent IBS and reduces the stress ulceration. What are the types of feeding we can continue? Oral feeding, nasogastric, and post-pyloric feeding. What are the contraindications for enteral feeding? If the patient having gastrointestinal obstruction or evidence of perforation or mesenteric ischemia, we have to avoid the enteral feeding. Feeding should not be held based on the gastric residual volume. If there is absence of bowel sound, we need not to stop the feeding. If the patient has signs of intolerance, we have to discontinue. If we have to discontinue, what are the signs of intolerance? Abdominal distension, discomfort, and emesis. And pain. In the ICU, very difficult to assess the pain, but some patients can communicate if the patient having on non-invasive ventilation, the patient can communicate, but if the patient is on invasive ventilation, patient can't communicate. So if the patient is communicating, we can assess the pain score by verbal rating scale, numeric rating scale, or visual analog scale. If the patient can't communicate, we can go for behavioral pain scale or critical care pain observation tool. In these scales, we can assess the pain according to the facial expression, upper limb movement, and ventilator. Fighting with the ventilation, we can assess how much the pain. There's a pain score. According to that, we can calculate it. What are the analgesia we can consider in critically ill patient? Usually, if the patient having mild pain, we can consider paracetamol. That is step 1 management. We can give 1 gram. Sorry. We can give 1 gram paracetamol 6 hourly. If the patient is not responding to the paracetamol, we can go for step 2. Step 2, we can consider PRN opioid bolus, or we can start the ketamine infusion, or we can consider alpha 2 agonist clonidine or dexmedetomidine. If the patient does not respond to step 2, we can go for the step 3. Step 3 is lidocaine infusion, non-steroidal anti-inflammatory drugs, and gabapentin, no pregabalin. If the patient having severe pain, we have to consider opioid infusion. What are the sedations in ICU? Intubated patient will generally require a sedative infusion. Usually we can use propofol because it is easily and rapidly we can titrate, but it can cause hypotension. On high doses it causes hypertriglyceridemia and it is risk for propofol infusion syndrome. Dexmedetomidine, it does not suppress the respiration. It is safe use in non-intubated patients, but it can cause hypotension due to bradycardia. And PTP, that is usually the patient with anxiety disorders, we can consider PTP, but it is the dose requirement of propofol and dexmedetomidine will reduce with the use of PTP. The benzodiazepine is usually the last choice, but it can be useful in hemodynamically unstable patients because the propofol, it will cause profound hypotension. Gastrointestinal prophylaxis. What are the gastrointestinal prophylaxis we can use? That is, we can use non-pharmacological measures and pharmacological measures. What are the non-pharmacological measures? We can, if the patient having on aspirin, we have to stop if no indication. If the patient is on non-steroidal anti-inflammatory drugs, we can avoid in ICU patient. If the patient, whenever the patient is, we can possibly start the earliest possible enteral nutrition. That is the one of the method for GI prophylaxis. Who need the GI prophylaxis? The intubated patient, non-intubated patient with the risk factors. What are the risk factors? The coagulopathy, profound uncontrolled shock, recent history of GI bleed, or patient is on steroid therapy taking more than 60 milligram prednisolone daily, and sick COVID patient with on dexamethasone. What is the preferable drug we can give? Currently, we are using pantoprazole 40 milligram orally or IV. Why it is superior to H2 receptors? Because it has greater efficacy compared to H2 receptor blockers, and it is possibly low risk of delirium compared to H2 receptor blockers. Initially, it thought increased risk of Clostridium difficile and pneumonia, but now after the new evidence trial, it is less. That is SQP ICU trial. It shows it can be used here. And anemia and transfusion, what is usually in the most of the ICU patient will have gradual decrease in hemoglobin. It caused by several factors. What are the factors it will cause? because of suppression of hemophysis by critical illness or phlebotomy for the several lab tests and subclinical loss from the GI tract due to the minor stress ulceration. How can we prevent this? We can give the conservative blood transfusion if the patient after the post-CABG or active MI, if hemoglobin less than 80, we have to consider blood transfusion. Others, if the hemoglobin is less than 70, we consider transfusion. We have to, as much as possible, we have to avoid frequent lab draws. And if the patient having evidence of source of bleeding, we have to control the bleeding. If hemoglobin drop without any explanation, we have to start proton pump inhibitors. It may be due to the minor stress ulceration. In ICU, the glycemic control is important because the patient has hypoglycemia or hyperglycemia. But hypoglycemia causes permanent brain damage and cardiopulmonary arrest. It is dangerous in intubated and sedated patients because they will present with hypoglycemia without any signs. The hyperglycemia will not kill the patient, but extended hyperglycemia may be dangerous to the patient. The outcome will be bad. In ICU, patients should receive occasional blood glucose check because to avoid the occult hypoglycemia. What's the target for critical illness patient? If the patient is poorly controlled diabetic, what do you mean by poorly controlled diabetes? If HbA1c is more than 7, we have to treat the glucose if more than 270 milligram per deciliter. Target blood glucose level is 180 to 250. If the patient is not poorly controlled diabetes, if HbA1c is less than 7, we have to treat the glucose level if blood sugar is more than 240. What's the target for that? 140 to 220. And in ICU patient, we have to consider the volume status of the patient. Usually the critically ill patient generally develop retained fluid because they will become fluid overload. Numerous studies correlate the positive fluid balance increase the mortality of the patient. So if the patient is gaining fluid more than 4 to 5 liters net positive, we have to require, the patient will require fluid restriction and dialysis. If the patient develops highly positive fluid balance, 4 to 6 liters is a hallmark for poor quality critical care. In ICU patient, we have to avoid the maintenance fluids unless indicated because usually we are giving enteral feeding and with the infusions all include the maintenance, normal maintenance. If some condition we have to give more maintenance fluid if the patient has diabetic ketoacidosis or if the patient has rhabdomyolysis, we have to replace the maintenance fluid. What are the maintenance fluid we can give in ICU? We can give plasmolite and we can give ringalactate is generally the fluid of choice in ICU. We have to avoid normal saline and we have restrict in metabolic acidosis. But in ICU setup, if the patient having increased lactate, not indication for fluid resuscitation because there are several causes for increased lactic acidosis. We have to check the volume status of the patient. If the volume depletion is there, we have to treat with fluid. Otherwise, not needed. And what are the ICU care bundles? Care bundles mean it consists of group usually 3 to 5 evidence-based intervention. They are related to particular condition or even inpatient care. What are the care bundles? We can see in ICU ventilator care bundles, sepsis care bundles, CVC care bundles, catheter-related care bundles are there. What are the ventilator care bundles? Because elevation of head end between 30 to 45 degrees, daily sedative interruption and assessment ready to extubate, septic ulcer disease prophylaxis and venous thromboembolism prophylaxis. In ICU patient, very difficult to detect the myocardial infarction because sometimes patient develop troponin elevated level. So what do you mean by myocardial infarction? Because dynamic rising or fall in troponin level, and we have to the clinical history suggestive of MI or new ischemic ECG changes or new wall motion abnormality on echocardiogram. We can divide it into non-MI troponin elevation, that is myocardial injury, type 1 MI, that is due to plaque rupture MI, type 2 MI due to demand ischemia. What do you mean by non-MI troponin elevation? That is usually they have elevated troponin level but no features of MI. Commonly, it will in ICU patient, but no treatment required. No need to do the serial troponin. In type 1 MI, they will present with classic MI due to the plaque rupture or acute coronary thrombosis. They will related to cardiac related symptoms. Typical treatment regime they required, but they need sometimes cardiac catheterization. Type 2 MI, there's a fixed coronary lesion plus physiological stress, and they can have the risk factors of anemia, sepsis, and hypoxemia. If the patient have elevated troponin, if a new changes of ECG changes, we can check the echocardiogram. There's a regional wall motion defect. We have to consider the patient having MI. What are respiratory support, non-invasive support in ITU? We can use BiPAP and high flow nasal oxygen. What are the contraindication for BiPAP if the patient has secretion or risk of aspiration or altered mental status? We have to avoid BiPAP because increased risk of aspiration. What are the indications for BiPAP? COPD, bronchial asthma, or cardiogenic pulmonary edema, obesity, hyperventilation syndrome? We can use BiPAP. In high flow nasal oxygen, the patient has significant respiratory distress who doesn't have specific indication for BiPAP. We can use high flow nasal oxygen to maintain the oxygenation, especially in pneumonia patients. Situation where the BiPAP is preferred, but yet the patient can't tolerate BiPAP, especially COPD or pulmonary edema, we can use high flow nasal oxygen. And these are my reference. Thank you. I thought about the supportive care of briefly because most of the topic will discuss delirium, pain, and sedation. They will explain in separate topic. That's why I touch briefly.
Thank you very much, Bhavani. And you covered majority of the points in a very concise manner. And whatever we are doing practically in ITU, they are justified by whatever you have presented right now. Does anyone have any questions? Dr. Ferenc, you can go ahead.
Yes, very nice presentation. I'd like to thank you for the nice preparation and presentation. Thank you.
Thank you, Dr. Bavani.
Does anyone else has any doubt, any questions or suggestions? Pin drop silence again. Anyway, Bhavani, I'll just quickly add some points. So you mentioned about level of care. So most of our patients who come to us will have some invasive ventilatory or cardiac support. So they become level 3 care, or sometimes some patients will require multiple supports at one go, like dialysis, some inotropes. So they also become level 3 care. Whereas in medical HDU, they come down to level 2 care. Now again in level 2, if I'm not mistaken, it's 2A and 2B. And our PACU and CMH ECU comes up to level 2A care, because if any other clinical signs of deterioration are seen in these patients, then they are straight away transferred to our ICU because they might deteriorate right up to level 3. And for that, there is also something called National Early Warning Scale, which is also called New Score. I don't have the table right now, but New Score uses your simple parameters like BP, pulse rate, and saturation, respiratory rate, need for oxygen, and any other clinical signs. And based on that, it is decided that where will the patient go, that is whether he can remain in ICU, I'm sorry, not ICU, whether he can remain in the ward or can he go to the any higher level of care. Okay. So that's it from my side. Mohit, do you want to add anything?
I think a very good presentation by Dr. Bavani. And she actually highlighted really important points in a very simplified manner, which is very useful for all of us in the clinical setting.
Even I
So
agree with you.
yeah, so that's very important because this helps us in remembering things when we encounter in a real life setting. I just got a message from Dr. Dean that he's busy in theater, and
Oh.
he's saying that he will log in as soon as possible. But yeah.
Okay, thank you, Mohit.
Shall we wait for another 5 minutes for Dr. Mike Dean?
Yeah.
And if
I
we
think if all of us agree on this, then it should not be a problem anyway.
what do you say, everyone? And by the way, I have mailed you the feedback form so that you can give feedback for Bhavani also.
Okay, thank you.